Yeah.
Thank you.
I'm here all day, so I'll check it out. Have lunch, on the battery running this.
Okay, perfect. Thank you. All right.
Did you try out? Oh. I imagine at some point we'll be going to your own PowerPoints.
Yeah, so.
Okay.
Perfect. Thank you. All right. Well, good morning, everyone. I just wanted to welcome all of you to this year's annual Winter Breast Cancer Symposium. This is our 13th year offering this comprehensive review of the latest updates and therapeutic advances in the treatment of malignancies. So I just wanted to go over a few housekeeping items. Please keep your cell phones muted throughout the event. After each presentation, we'll take about 10 minutes for any questions. So feel free to ask our speakers. The event is being recorded and will be uploaded to our event website at a later date. I also wanted to thank all of our valuable industry partners for joining our event. The Nebraska Oncology Society would not be able to fulfill its mission without their partnership. This event is designed to present a comprehensive review of the latest updates and therapeutic advances in breast malignancies. Continuing education credits are available for this event. Complete the evaluation on our event home page and you will get your certificate. The evaluation will be available next week and you'll receive an email once it is live. I will now turn it over to Dr. Block, our program chair for this event at the Nebraska Cancer Specialist.
Okay, well, thank you everyone for coming today. We always have a good review for San Antonio Breast Cancer Symposium. Our first speaker is Dr. Gradishar. He is a well-known researcher in breast cancer research. He did all of his training in Chicago, having graduated from medical school at the University of Illinois Abraham School of Medicine. And then he did his residency and chief residency in internal medicine at Michael Reese Hospital in Chicago. And went on to his fellowship in medical oncology at the University of Chicago. He is now chief of the Division of Hematology and Medical Oncology at the Feinberg School of Medicine at Northwestern University in Chicago. And his main concentration in research is the development of new and novel therapies for treatment of breast cancer, particularly those that fit into the category of precision medicine, trying to tailor treatments more specifically to specific abnormalities that might be more directed towards the breast cancer treatment and the different types of breast cancer. He's published numerous articles. I think he's always at the San Antonio Breast Cancer Symposium, and he's very well known in his field. And I'll give you Dr. Gradishar.
Thank you very much for the kind invitation as well as the introduction. And let me share my screen. So what I was asked to talk about today, and I'm assuming you can see my screen, is that correct? Okay, so what I was asked to cover today is rather broad, and I can't help but think some others who will be speaking after me are going to perhaps overlap with some of the elements of my talk today, but maybe this will just set the groundwork for more in-depth discussion. So there were some very specific things in the invitation I was asked to talk about, and with time limitations, it's hard to go into great detail and cover everything about, obviously, breast cancer, but I'm going to try and cover the things that I thought were important and try to put them in perspective with respect to how we think about using these in the algorithm of treating breast cancer, both early and late stage disease. So let's get going. If this will advance, that would be great. So if you look at the NCCN guidelines, and I would tell you that probably next week, there'll be some subtle changes in the appearance of this table. But for all intents and purposes, the lineup of drugs we have available is listed here. And what's important is, as of today, the Cleopatra regimen, which is viewed as dual HER2 targeting plus a taxane, remains our first choice. Thereafter, we have drugs like trastuzumab deruxtecan. TDM1 will probably get moved down a little bit. And then, of course, we have the HER2 climb regimen with tucatinib. And then thereafter, we have all kinds of different options that we could consider using, sort of the Wild West. Okay, that's not the direction I want to go. So if you look at the Cleopatra data, which is now long follow-up, we have convincing evidence that dual HER2 targeting is better than chemo plus trastuzumab, at least with the taxane. And there was a quite remarkable survival benefit that was observed at that time. And this is why this has held the #1 spot for so long. And of course, thereafter, we had, lapatinib for some time as the second-line therapy after trastuzumab. The Amelia trial, which I'm not showing you, I don't want to spend too much time on distant history, but TDM1 replaced lapatinib and capecitabine as the second-line therapy. And then when we go forward to the present time, we can see that what we are going into are the era of antibody drug conjugates beyond TDM1. So here is the Destiny-03 trial, which utilized the antibody drug conjugate trastuzumab deruxtecan, which was compared to TDM1. And again, TDM1 at the time was viewed as the second-line best therapy following progression on a trastuzumab-based regimen. And if you look at the data that is starting in the upper right, PFS, lower right, overall survival and overall response rate was markedly improved with utilization of TDXD or trastuzumab deruxtecan. And these data were quite compelling and led to early embrace of trastuzumab deruxtecan and ultimately approval. And these data were, of course, updated by Sarah Hurvitz recently at San Antonio, as shown here. And with longer follow-up, I think the message that one can take away is the benefit is sustained. In fact, the PFS is now 4 times greater with TDXD versus TDM1. And you can look at different landmark time points of 1 year or 2 years, and the distance between the curves is pretty convincing. Similarly, if you look at overall survival with the updated data, the chances of dying are reduced by about 36%. And although both groups of patients, as just general statement, are still doing well, the TDXD treatment arm is doing better. And if you look at the fraction of patients who, after disease progression, went on to the opposite therapy, in those receiving TDXD, about a third of patients received TDM1, and going the other direction, TDM1 to TDXD, about 17% of patients. The reason this is important is because there is a lot of discussion about whether you should switch to a different kind of agent at the time of disease progression. And we don't have a clear answer what the best path is at this point. We'll have more data as time goes on. One of the big issues with trastuzumab deruxtecan at the outset was this concern for interstitial lung disease. And this was observed in the early trials, including a couple of deaths that actually occurred, so grade 5 pneumonitis. As there was greater use of this drug, not only in breast cancer, but in other diseases, and greater experience by clinicians utilizing the drug, I think sesensitivity to any respiratory symptoms, any concern about the onset of interstitial lung disease led to, discontinuing or being very aware of it. And when you look at the updated data from Destiny-03, which is shown in this table, you can see that the frequency or incidence of grade 4 or 5, severe ILD is quite uncommon. Still about 15% of patients will develop something that appears to be an ILD-like consequence of using the drug, but none of the severe side effects that we were concerned about early on. And there's a great deal of work trying to understand why certain patients develop this versus others. At the outset, it was thought perhaps Asians were more likely to get it, but we still don't have a specific phenotype of patient where we think this is most likely to occur. Now, when you look at where we're going next, I mentioned that one of the issues is, can we use sequential antibody drug conjugates? So there was the Destiny BO2 trial that looked at patients previously treated with TDM1 who subsequently went on to either TDXD or whatever would have been viewed as the choice by physician. Could have been trastuzumab in CAPE or lapatinib in CAPE. If the trial was done today, maybe there would have been other options. But this really addresses the issue of sequential antibody drug conjugates. And again, when this data was updated at San Antonio just a few weeks ago, we see that the PFS in those who receive TDXD versus any other option the physician might have chosen that was allowed in this trial, TDXD treated patients did much better. There was basically almost a tripling, or at least 2.5 times improvement in PFS with TDXD versus the alternative. Similarly, when you look at overall survival, the same relationship, there's about a 13-month advantage. 1-year and 2-year landmark analyses, TDXD was much better. So again, pretty compelling evidence that TDXD is very active even post-TDM1. Now, what will happen with this drug as we go forward, we don't know yet, but there's obviously lots of work being done. And there is a challenge to the Cleopatra regimen as a first-line therapy in Destiny 09. No data yet. But as you can see, this is an untreated patient population where they'll be randomized in red. You can see sort of the Cleopatra-like regimen, or TDXD plus pertuzumab or TDXD alone. And based on these results, we may see TDXD or trastuzumab deruxtecan pushed up closer to the front when patients first develop metastatic disease. Now, the other big development, of course, in the last couple of years is the utilization of tucatinib, and that was developed as part of the HER2 climb regimen. In the upper left, you can see that there's the IC50 for tucatinib is very good with relation to HER2, so much more selective compared to, say, lapatinib. What it also has an advantage of is that it has less off-target effects. So EGFR, the IC50 is greater than 10,000, meaning that you would have to use a huge dose to really be affecting that pathway. And as a result, the side effects would be expected to be less. The phase 1 trial, which is shown below, demonstrated that with the combination of tucatinib, capecitabine, and trastuzumab in heavily pretreated patients, including those with brain mets in orange, had responses. And of course, there's always the anecdote where things disappear in the lower right. So that led to the HER2 climb regimen in the upper right, 2-to-1 randomization in patients with metastatic breast cancer. Importantly, those that had progressed after pertuzumab, trastuzumab, and TDM1, and they could have had brain mets, and almost half of the patients did, untreated in 22%, treated but progressing in 18%. And the randomization was between the triplet of CAPE, trastuzumab, and tucatinib, or capecitabine and trastuzumab. And as you know from the results of this trial, overall, forget the brain met issue, it was a positive trial. And there was an improvement in PFS at 1 year that was basically 3-fold greater with tucatinib, and the median PFS improved by about 2 months. So a pretty impressive outcome for this trial overall. And similarly, when you look at overall survival, at both 12 months and 24 months, those sort of landmark time points, a significant improvement favoring those who received tucatinib as part of their regimen. And the median overall survival was improved by about 4 months. Now, one of the big bylines of this trial was the effect on the brain, which is shown on this slide. And if you start with the table on the right, it gives you fairly convincing evidence that almost half of the patients had intracranial responses to the tucatinib regimen. So more than double what you would see with trastuzumab and capecitabine, speaking to the effect of tucatinib. In patients, all comers with brain mets on the top left, you can see that PFS in the brain is markedly improved, as is overall survival. And interestingly, in the patients with active brain mets, not treated, but active, a similar effect is seen in the lower left. Both CNS PFS and overall survival is significantly improved. And of course, that speaks to the question of whether or not can we see similar effects with other drugs. Well, if you go back in the day a little bit, there is anecdotes with basically any drug you give to having an effect in the brain. Capecitabine, neratinib, most of those monotherapies were not all that effective. Certainly combining lapatinib cape, combining neratinib cape had better activity than monotherapy. We've had this dogma that big molecules like monoclonal antibodies don't get into the brain, but the Camilla trial with TDM1 showed that there was activity. And there have been a series of small experiments. This is from a paper published just a couple of weeks ago in Clinical Cancer Research, collating the trials that have looked at the use of trastuzumab deruxtecan in the brain. And although it's a little bit difficult to see, if you look to the fourth column, you can see that across the different trials, different experiences with admittedly relatively small numbers of patients, there are response rates in the brain of anywhere from 50 to 70 some percent. So the dogma of getting antibody drug conjugates into the brain is probably false. You can do it. And of course, the experience is still relatively modest. There's a lot of work going on to look at this agent in CNS brain mets. So today, if you looked at how we think about treating metastatic HER2-positive disease, we still have the Cleopatra regimen up top. Trastuzumab deruxtecan and the tucatinib-based regimen are really second-line choices. And then, depending on what you did or didn't get, you'd probably sequence the alternative in the third line, and thereafter it's the Wild West. Now, I chose not to talk a whole lot about two other drugs, neratinib and margetuximab. I think they're still relegated more to later lines of therapy, but these become options, I suppose, once you're past the third or fourth line. But there wasn't anything all that new with those drugs at San Antonio. Now, a drug we may hear about in the near term is trastuzumab deocarmazine, another antibody drug conjugate. This is not unlike TDM1 or trastuzumab deruxtecan in concept, an antibody targeting HER2, a linker, and then a cytotoxic payload, in this case, a DNA alkylating agent. And we had phase 1 data, not shown here, but demonstrating that it was active in patients previously treated. Most patients did respond. And that led to the TULIP trial, which is shown here, which was presented a year and a half ago or so, in which patients who had gotten up to two HER2-targeted regimens, including TDM1, were randomized to trastuzumab deocarmazine or physician's choice, which again could have been a variety of CAPE combos, lapatinib trastuzumab CAPE, or trastuzumab eribulin, or vinorelbine. And as you can see on the upper right, the PFS was improved by 2.5 months or so with trastuzumab deocarmazine, a suggestion, though not statistically significant, of a survival benefit favoring trastuzumab deocarmazine. So whether this drug will be approved or not, there is a phase 3 trial behind it, and we'll just have to see if we have this available in the near term. Now, I want to transition to the other big story in the HER2 space, and that is, of course, HER2 low disease. We sort of had a binary way of looking at this in the past. You were either HER2 positive based on IHC3 plus or IHC2 plus and FISH positive, and then everything else was negative. But there is a category now that we think about, or I shouldn't say a category, but a way of looking at HER2 that includes HER2 low, which could be IHC1 plus or 2 plus without FISH positivity, and that accounts for about 50% of patients. And that may have been an irrelevant observation until we had therapeutics that looked like they were active in this setting. Now, if you go back in time to NSABP-B47 in the adjuvant setting, this was a large trial that was evaluated to determine whether the addition of trastuzumab in the adjuvant setting would add anything to standard adjuvant chemotherapy. And if you look at the upper right, the answer is pretty clear. There was no added benefit to trastuzumab in that setting. So, the question became whether or not any form of therapy in this HER2 low population would be of benefit. Now, prior to DB04, there was a phase 1/2 trial looking at low expression of HER2 and TDXD in a small population with IHC 1+ and 2+ FISH negative, there was roughly a 30% response rate. So this became intriguing and led to the DB04 trial shown here. HER2 low is defined as IHC 1+ or 2+ but FISH negative and treated with 1 to 2 prior lines of chemotherapy in the metastatic setting. And this was a population that was largely hormone receptor positive. So out of the total population, 480 were hormone receptor positive and only 60 were hormone receptor negative. And it was a comparison 2-to-1 of TDXD versus treatment of physician's choice, keeping in mind that if standard of care would have been, if you were endocrine refractory, that you're going to get chemotherapy. So any of a number of chemotherapy choices were chosen. And these are the data which got such a warm embrace by everybody who saw it immediately, a standing ovation. And that is that PFS in the overall population on the right was more than double with TDXD. And if you look at the largest fraction of patients, which are positive, similarly, a doubling of the PFS. The overall survival was similarly enhanced by about 5 months, 6 months in the overall population and in those that were hormone receptor positive. And if you look at the 60 patients who were hormone receptor negative, although it's too small and it's exploratory, you get the sense that it's active there too, with an improvement in PFS as well as overall survival, but not statistically significant. And similarly, response rates in the overall group as well as in the individual receptor positive, receptor negative patients clearly favored TDXD over the alternative. So this quickly became embraced by the clinical community, and I think we're in search of patients who have any level of HER2 expression to at least make trastuzumab deruxtecan a consideration. Now, one of the questions, of course, is how low can you go? And with that, I mean, is there some evidence that even in HER2 0, that this might be an active drug? And sort of an exploratory trial looking at a number of different biologic translational questions is the DAISY trial. And this had different cohorts of patients, including those who were IHC 3+ all the way down to IHC 0. And as you might predict, as the level of expression went down, the response rate went down, and you can sort of see the effect on PFS if you can see my arrow. But the important thing is if you look at these patients in the last cohort who even had non-detected HER2, there was roughly a 30% response rate. The duration of response was almost 7 months, and PFS was 4.2 months. So it does beg the question of whether you might benefit from trastuzumab deruxtecan, even if you're IHC 0. And that question is being addressed in one of the DB or Destiny trials, Destiny B06, where there is a HER2 ultra low population, roughly 100 patients in a much larger group, where there is that comparison of trastuzumab deruxtecan to different chemotherapy choices. No data, but we'll see if there is activity in this ultra low population. Now, let me switch gears to the adjuvant setting real quick. And as I said, you can't be exhaustive with the amount of time that we have, but this is sort of the pick list for the adjuvant setting from the NCCN guidelines. And I will say that this will not change in any meaningful way when this is posted, I think, coming this week. It'll look very much the same. I want to jump forward because, you know, we think that everybody that has HER2 positive early stage breast cancer must get some form of adjuvant HER2 directed therapy. And we've sort of gotten into the mode of giving dual HER2 targeting. And it's important to remember that there are patients who don't need all of that. And a lot of the work from the APT trial by Sarah Talani and her colleagues really gave the foundation for considering less is appropriate for some of these patients. And at San Antonio, we had long-term follow-up at this trial. You know, as you look on the lower left, you can see that about half of these patients had tumors less than 1 centimeter in size. There were a small fraction of patients, about 9%, who had tumors up to 3 centimeters, and 2/3 were hormone receptor positive, keeping in mind that this was 12 weeks of weekly Taxol or paclitaxel and a year of trastuzumab. And what the data showed at 7 years is shown here, obviously 3, 5, and 7 years DFS Recurrence-free survival was excellent. Very few patients recurred. And now we have the 10-year follow-up, and there are a few patients that drop off with recurrences, but still the DFS is greater than 90%. Relapse-free interval is greater than 95%. And distant recurrences, although they can occur, are relatively uncommon in this population. So I think it's important to point out, thinking about this regimen, that this is something that can be considered. It's in the guidelines supported at ASCO, NCCN, ESMO, et cetera, St. Gallen. But it's also important to remember the contrary, that is that not every single patient that happens to have HER2 on their tumor needs adjuvant therapy with trastuzumab. So I would submit that if you had a patient with a 1 or 2 millimeter area of invasive disease, it's not absolutely necessary or that they must receive chemotherapy with adjuvant trastuzumab. Now, there was an effort to try and make this more tolerable, and that was the ATTEMPT trial shown here, TDM1 versus the combination of paclitaxel and trastuzumab. And again, about 40% of patients had tumors less than a centimeter. Most were hormone receptor positive. And the idea was, could you make a more friendly regimen for lower risk disease? Because TDM1 would presumably keep some of the hair, and TH is more associated with neuropathy and alopecia. That was seen in this trial. And the money slide is really in the upper right. That is that the disease-free survival, relapse-free interval was exactly the same. They were completely overlapping at 3 years. We now have longer follow-up from San Antonio this year. And again, you can see the APT regimen, which we talked about earlier, compared to the ATTEMPT trial with TDM1 and TH. And as you follow patients out at 3-5 years, as a general statement, they do very well, and both groups do very well. So I think this could be considered a reasonable option for certain patients if, for whatever reason, they didn't want to have hair loss or there were some other reasons. But it's important to keep in mind that with TDM1, more patients had to discontinue because of intolerance. So there were, it wasn't always user-friendly for everybody. There are efforts to de-escalate further. The ATTEMPT trial on the left is looking at TDM1 only for 6 cycles and then subcutaneous trastuzumab for the remainder of the year versus the APT regimen, but this time with sub-Q trastuzumab. And in patients that are ER positive, there's an effort to determine whether subcutaneous trastuzumab and pertuzumab plus endocrine therapy in the absence of chemotherapy may actually achieve similar good results. And we don't have data from any of these trials at this time. Now, we know that in patients with higher risk, we're more inclined to give dual HER2 targeting. And this is the affinity data updated at ESMO in July. And I think what we now appreciate is that overall, the lines are pretty close together. And if you're looking for where the benefit really lies with the addition of pertuzumab in the adjuvant setting, it's largely in patients who are node positive. So I think there are a significant group of patients where pertuzumab is not actually required because there's little additional benefit, but certainly in node positive disease, the answer is yes. We also know from Catherine that if you get pre-op therapy, as so many patients with HER2 positive disease do, with a dual HER2 targeting regimen, say TCHP as an example, and they have residual disease, this trial demonstrated that TDM1 rather than trastuzumab improved the overall outcome. And the absolute improvement in DFS was about 11%. So it was significant, and this became, a standard of care, regardless of the size of residual disease. So this is something we commonly do in practice. And there are further efforts to try and improve that outcome. The COMPASS trial, which many of us are participating in, is looking at whether the addition of tucatinib to TDM1 in that setting would further reduce the risk of recurrence. And of course, trastuzumab deruxtecan has to be somewhere in the mix, and that is being compared to TDM1. And then there is still some interest in adding immunotherapy to targeted therapy in this setting. And although there was the Impassion 050 trial that didn't show any improvement in PCR rates with the addition of atezolizumab, This is a post-op trial looking at residual disease patients. So we'll find out if, again, a drug like atezolizumab can add to the effects of targeted HER2 therapy. So when you think about where we are with HER2 positive disease, we've made a lot of progress in both the adjuvant and advanced disease setting. And I'm going to transition now to ER positive disease. And starting with metastatic disease, this is sort of what a reasonable algorithm might look like. CDK4/6 inhibitors clearly have the frontline approach for the vast majority of patients. Thereafter, if you happen to have a germline mutation, you could consider aliperib or talazoparib. In the 40% of patients who have a PI3 kinase mutation, alpelisib could be considered. But if those things are not options, then we go on to fulvestrant or perhaps exemestane and everolimus. And then we start getting into the arena of HER2 low disease and how we utilize some of the antibody drug conjugates. And I will say that as of, and we'll talk about it in a few minutes, as of yesterday afternoon, elacestrant was approved. So we'll have that drug available to us in the clinic very soon. So that's an approval hot off the press. In a single slide, these are the data from the CDK4/6 inhibitor trials. I think everybody's very familiar with them, whether you're talking about first line or second line. Uniformly, the CDK4/6 inhibitors show an improvement in PFS, either in combination with an aromatase inhibitor or fulvestrant. And the question then becomes, is it uniformly effective from an overall survival standpoint? And we have data with certainly with ribociclib and abemaciclib showing an improvement in survival depending on the trial, but less compelling at this point with palbociclib, but all clearly very active drugs. The question becomes, when you progress after a CDK4/6 inhibitor, what should be the next step? And, there has been a lot of interest in whether or not you could give a either alternative CDK4/6 inhibitor or simply switch out the endocrine therapy and keeping the CDK4/6 inhibitor going. And the first trial that really looked at this from ASCO last year was the MAINTAIN trial, which was a small study, but it was patients who progressed on endocrine therapy and a CDK4/6 inhibitor. And most of the patients who progressed had received palbociclib, about 90% of the patients. And the endocrine therapy that they had received prior was usually an endocrine agent, either with an aromatase inhibitor or fulvestrant. So at progression, they were randomized to ribociclib and a switch of endocrine therapy, or they were not continued on the CDK4/6 and simply had the endocrine therapy switched. And if you look at the data, the PFS on the left was improved by a couple of months with the switch from, for the most patients, from palbociclib, which they had progressed on, to ribociclib as defined in this trial. And on the right, where you see the greatest benefit is perhaps counterintuitively in patients who had wild type estrogen receptor, no estrogen receptor mutation present. So that's the curve on the left. We might have expected where the benefit would have been greatest was in those with ESR mutations, where the lines are completely overlapping. So this was the first hint that maybe sequential CDK4/6 inhibitors might be helpful, but it's important to keep in mind there were a lot of things going on, including switching the endocrine therapy. A trial that was presented at San Antonio is shown here, and this is the PACE trial, in which patients with hormone receptor positive HER2 negative disease who progressed on a CDK4/6 and endocrine therapy were randomized to either fulvestrant or fulvestrant plus palbociclib, or the third arm where they got all three, which was fulvestrant, palbociclib, and an immunotherapy. And if you look at the primary endpoint, which is PFS shown on this slide, I would draw your attention to the red and blue lines, which are pretty much overlapping, because that gets to the question of whether continuing a CDK4/6 inhibitor made any difference. And you can see on the table, the median overall survival was identical. So not very compelling evidence. So we have somewhat contrary results. Now, of course, the other element here is the addition of an immunotherapy, which isn't standard, but it seemed to suggest that there was some improvement with the addition to making it a triplet with a CDK4/6 inhibitor and fulvestrant. So we still have sort of cloudy data on how to think about this. It's not for everybody, certainly, to switch to a different CD4/6 inhibitor or continue it, but it would be a consideration based on these data. And of course, in those patients who have a PI3 kinase mutation, we do have data from the SOLAR-1 trial showing that in patients with a mutated PI3 kinase, the addition of alpelisib makes a difference, whereas if you had wild type or non-mutated PI3 kinase, it didn't make any difference. These are the data from the cohort that had a PI3 kinase mutation, showing a doubling of the PFS, favoring the addition of alpelisib. So this is a consideration. Again, we know that this is not always an easy drug for many patients. And you have to be very aware of not only dermatologic, but endocrinopathies inducing diabetes. So this can be a difficult drug for some patients and physicians managing. Now, I want to transition to a large, area of research. It's sort of a word salad, and this slide is not encompass everything, but these are drugs you've all heard about, the class known as the SERDs, and there's a lot of work in development. Some of these drugs have already been discontinued in terms of development. MSS, the AMERA trials were negative, so those are, gone. And there are others that are still moving forward. And I already mentioned that based on this trial, the EMERALD trial, elacestrant was approved yesterday. And the data that supported that approval, I'll show you in a moment. So the EMERALD trial was a randomization between elacestrant and treatment of physician's choice, any of a number of endocrine therapies. Patients who were in this trial had progressed after 1 or 2 prior lines of endocrine therapy, one of which had to be a CD4/6 inhibitor. And these are the data that Aditya Bardia presented, showing that for all patients, there was about a 30% reduction in the odds of disease progression. Numerically, it doesn't look that impressive if you look at the table, 2.8 versus, it's a matter of weeks. On the right, in those patients who had a mutation in ESR, it was about 4 months versus 2 months, so a bit more impressive there. And it's really on this cohort that it's approved. So for those patients with mutated ESR, elacestrant will be available. And if you look at landmark time points on the left for all patients, more patients are without disease progression. And specifically on the right, in patients with ESR mutations where this drug is approved, we see that at 1 and 2 years, at 6 and 12 months, more of the patients receiving elacestrant are without disease progression, doubling to tripling at the different time points, the fraction of patients who don't have disease progression. So I suspect this will be available, will be used, and we'll be looking for ESR mutations now if we haven't been in the past. So as I mentioned, some of these drugs have not gone forward, and we still have a number of trials we're waiting to hear about. We heard about a few of them at San Antonio a few weeks ago, and I anticipate that there will be more data coming. How many of these drugs will actually find their way into the clinic remains unclear, but we'll have one in very short term, that's elacestrant. So I want to talk a little bit about the use of antibody drug conjugates in the HER2 negative hormone receptor positive space. And the TROPICS-2 study, which was presented at ASCO by Hope Rugo, is shown here. These are patients with metastatic disease who'd progressed after 1 endocrine therapy, as well as inclusion of a CD4/6 inhibitor. They had to have received a taxane. And you can see the randomization is between what we would think of as standard in this setting if you weren't responding to endocrine therapy, and that is chemotherapy. And there's a number of different choices. So randomization between sacituzumab govitecan and treatment of physician's choice, PFS was the primary endpoint. And if you look at the data from this trial, patients with sacituzumab had a better outcome with respect to staying free of disease progression on the left. 6, 9, and 12 months, more of the patients were without disease progression. And on the right, clearly an improvement in outcome if you look at the fraction of patients who are alive at 12 months compared to those receiving treatment of physician's choice. And taking into account what were the therapies that patients had gotten prior to this, Specifically on the right, if you look at endocrine therapy, everybody essentially had gotten endocrine therapy. Everybody had gotten a CDK4/6 inhibitor. And there were a variety of chemotherapy drugs utilized previous to going on the trial. CAPE, paclitaxel, and eribulin were fairly common. And the use of a CDK4/6 inhibitor in 60% of patients was less than or equal to 12 months prior to participating in the trial. So I think that based on these data, this becomes an option. And at San Antonio, there was an effort to look at whether the level of TROP2 expression made a difference in the likelihood of benefiting. Now, the important thing is to keep in mind this was looked at in the ASCENT trial, which was the trial that led to the approval of sacituzumab govitecan in triple-negative metastatic breast cancer. And whether you were TROP low, medium, or high, the use of sacituzumab govitecan was better than chemotherapy, a physician's choice. So in this study, about 80% of the patients in both groups in the TROPiCS-02 study had samples that were available to evaluate for the level of TROP2 expression. And you can see the distribution. There were a small fraction who had no level of expression, 12% less than 10, and less than 100, about a quarter, and then greater than 100 in about 60% of patients. And without showing you each of the individual slides, I was going to simply cut to the chase and say that progression-free survival and overall survival across all the groups was improved with sacituzumab govitecan over treatment of physician's choice. So again, I think this becomes an option in endocrine refractory patients, and we're starting to see emerging data with other antibody drug conjugates as well. Now, the other big story is the Capitello trial that came out of San Antonio, and this is an AKT inhibitor. This was a trial conducted in hormone receptor positive patients who had up to 2 lines of prior endocrine therapy and up to 1 line of prior chemotherapy for advanced disease. And the randomization was between capivasertib and fulvestrant or fulvestrant alone. And if you look at the pathway alterations, which were present in about 40% of the patients in both groups, the vast majority of PI3 kinase mutations, a small fraction at AKT and PTEN alterations, and about 50 to 60% of patients had no alteration in these pathways. If you look at PFS in the overall population, it favors those patients who got capivasertib. So the combo of capivasertib with fulvestrant was better than fulvestrant alone. And if you look at those with an AKT altered pathway, it's similar. There's basically a doubling of the PFS if you add either a PI3 kinase, AKT, or a PTEN abnormality. And in the non-altered population, which again was about 60% of the patients, you see a similar effect. So it doesn't matter if you have the mutation or not, seemingly, although this is exploratory, that you got benefit from the addition of capivasertib. So we need longer follow-up with this trial, but if you look at the toxicity data from this trial, which I didn't share, it looks like it's probably somewhat better than the choice of alpelisib. So we'll have to see if this drug is approved, how we sequence it, how we use it, because the combination in this trial is with fulvestrant. So I think this is something that may be coming soon. Now, the last piece I want to touch on quickly is the use of adjuvant endocrine therapy. And one of the things I was asked to talk about, or at least to discuss, is the SOFT trial or soft text trials. I don't think we can exhaustively cover all of this, but we've known for decades that if you ablate the ovaries in premenopausal women, you have a chemotherapy effect that's not unlike what you see with CMF. So this is ovarian suppression ablation versus doing nothing. And not surprisingly, there's a benefit in terms of recurrence and breast cancer mortality. We've long known that. Similarly, if you look at young women who either get tamoxifen or not in ER-positive disease, it's pretty clear that the addition of endocrine therapy reduces the risk of recurrence in a meaningful way, about 10% in both parameters, recurrence and breast cancer mortality. And if you sort of collate the data from several of the Oxford overview analysis, we know that tamoxifen reduces risk by about 1/3 breast cancer mortality. We've known it has a prevention effect on the contralateral side, cutting the risk by about half. And we've long known what the risk profile is with respect to side effects, uterine cancer, thrombotic events, low but real events. So when we think about the current contemporary status of how we think about ovarian suppression, a large extent it's based on the SOFT trial, as well as the text, but I'm going to focus on SOFT because this was discussed at San Antonio. And as you recall, this was a trial where patients could have gotten chemo or not, physician discretion, positive or negative nodes, with about a third of patients having positive nodes. And they were randomized between tamoxifen or either tamoxifen ovarian suppression or exemestane and ovarian suppression. And the long-term follow-up now with 12 years clearly shows that ovarian suppression in this younger population impacts with the reduction in the odds of disease progression, more so with the use of an aromatase inhibitor than not. And if you look at the overall survival, including the third of patients who had lymph node positive disease, you have to sort of strain your eyes, but the lines are separate with a 12-year median follow-up of about 2 to 3% in absolute terms, favoring the addition of ovarian suppression, either with tamoxifen or endocrine therapy. And if you look at the keep in mind that physicians could choose, do I give chemotherapy or not? And those that did not get chemotherapy, who tended to be older, less likely to be node positive, the median follow-up, the lines are starting to look pretty superimposable. And the absolute differences between these lines are starting to get diminishingly small. So the advantage in this group is less with ovarian suppression, but there is a hint of some added benefit, particularly with exemestane. And in the group that had a higher risk, so younger patients, positive nodes in almost 60%, we start to see the lines coming apart. And specifically, when you look at overall survival, you can see that compared to tamoxifen alone, the addition of ovarian suppression with or without exemestane or tamoxifen clearly offers an advantage, both in terms of recurrence-free survival and overall survival. And even in the HER2 negative group, where they knew definitively there was no evidence of HER2 expression, ovarian suppression added additional benefit, and more so doubling in those who got exemestane and ovarian suppression. So sort of a summary in the very youngest women based on the data from SOFT is that you reduce the risk of an invasive event by about half, and the 12-year overall survival is improved significantly if you add ovarian suppression. And ovarian suppression in this very young age group with follow-up at 12 years does provide a meaningful improvement in outcome. So you could think about how we use adjuvant endocrine therapy, particularly with respect to ovarian suppression, somewhat based on risk. And there are patients who can get away, young patients, with tamoxifen alone. And I'll talk about what they look like. But, you know, we have tamoxifen for 5 years, perhaps in those patients, somewhat higher risk. We can use the Atlas and Adam trial to go longer. And then as we get into the more generic kinds of patients who become postmenopausal, sequence it with an AI. And then, of course, ovarian suppression with the very youngest and highest risk patients. And these are the patients who tamoxifen alone might be okay. HER2 negative, node negative, small tumors, ER high expression, and Ki67 low. Now, the last thing I want to comment on is adjuvant CDK4/6 inhibitors. Without going through the detail of all the trials, the top and bottom are trials that either have been reported or not reported. So Pallas and Penelope with palbociclib failed to demonstrate an improvement in outcome. With the Pallas trial in the adjuvant setting, no improvement with the addition of palbociclib. Penelope with residual disease. In those who had residual disease, the addition of a CDK4/6 inhibitor did not show any improvement. And Natalie, which is looking at 3 years of ribociclib, has not yet reported. So let's focus on Monarchy. Monarchy shown here. This was a big trial, as you know, 5,000 plus patients who received standard endocrine therapy, and then either the addition of abemaciclib or not. And there was also 2 cohorts, including one who had high risk based on Key 67. And these are the primary endpoint of this study was invasive disease-free survival, as well as looking at overall survival, safety, et cetera. And in a single slide, this is the distant relapse-free survival and invasive disease-free survival on the left. And again, there is an advantage for those patients receiving abemaciclib with about a third reduction in the likelihood of experiencing DFS events. And that translates into about a 5% improvement in outcome at 3 years. And on the right, a similar 1/3 reduction in developing a distant relapse-free survival event, also about an absolute 4% improvement at 3 years. So the FDA, ASCO, NCCN all approved this based on the criteria that allowed entry into the study. And as a result, I think for select patients, we're now using this. We're waiting on the NATALEE trial to see if we'll have benefit from ribociclib for a longer duration of therapy compared to the 2 years with abemaciclib, and those data are anticipated in the near future. So my last slide is this one, and that is how we think about early stage disease. Certainly, if you have a tumor that's, this is more the HER2 positive discussion, but if you look at tumors less than 2 centimeters in size, as I already mentioned, we have a number of options, the ATP trial or even the ATTEMPT trial. In patients who have larger tumors, we tend to think of preoperative therapy. And if they have residual disease, we give the Catherine regimen. But we're now looking at whether we can reduce the chances of recurrence by a number of different strategies, including looking at the addition of tucatinib to TDM1 or obviously TDXD compared to it. If you have a PCR, then we simply continue with trastuzumab if they're node negative, HP if they're node positive, and then the endocrine discussion that I just had would be applicable to all of these patients if they're ER positive. So with that, I'm going to stop and be happy to take any questions, should there be any.
Well, I have a question. Can you hear me?
Yes.
We seem to struggle with patients who are worried about not regrowing their hair with Taxotere. And so it seems like I have been using more AC and then THP, following AC. And we do have a Dynacap machine, which I think has been successful, but we can only treat one patient a day on it. So I just wondered, are you running into that also?
Well, I'll be, I guess it's always a tension because there are patients, though they're not that common, who don't regrow their hair, but there's obviously a group of lawyers making a living on, Taxotere-related alopecia. But that said, the other competing risk, of course, is anthracycline-induced cardiac problems, although rare as well. And I think we know that when you use a non-anthracycline-based regimen with HER2-directed therapies, the outcome is the same. So I guess if one were really concerned about alopecia that was permanent, I wish we had a marker for that. To the best of my knowledge, we don't. There's no disadvantage in terms of efficacy with using an anthracycline. So that could be done, and I don't think that's a major issue. And we too, have limited access to cold capping and so forth. It's not uniformly available for everybody. So I guess the best way to answer the question is, if that is a concern, the anthracycline-based regimens are not inferior in any way to a taxane-only regimen.
Okay, thanks.
Can I ask something else? Just a question. What's your thoughts on the new oral SERD? it seems interesting that they stratified it based on ESR1 mutation, but we don't do that with fulvestrant. Do you think that we're, if we were to, I guess, if we were to look at the ESR1 mutation and fulvestrant, do you think our outcome would be similar to the new oral SERD? And how do you see that new drug sliding into your practice?
Yeah, well, I think that's a good question. I think people are going to, as usually the case, anything that's new will get used. So that's number one. So I think people will be excited to have something available. We will, in order to use it, have to make sure patients have ESR mutations. And we've known for some time that if you have an ESR mutation and we're thinking about re-exposing a patient to an aromatase inhibitor, it's less likely to be effective compared to fulvestrant. So the question then becomes, as you pointed out, if you have an ESR mutation, are fulvestrant and elacestrant going to be equally effective, or is one easier than the other? Even if they're equally effective, I think offering a patient something they can take orally could very well be more attractive than giving them an IM shot into their buttocks, once a month. So even if all things are equal, I think that becomes a little bit more attractive. Whether they'll be, and you saw the efficacy data. The efficacy data is there, but it's not, it's not the CD4/6 kind of added advantage where you're adding a year of PFS. It's much more modest. So I think we'll see. And these drugs are going to be obviously evaluated in combination with other targeted therapies. And that data will take a while to be generated. But my view is that it will be used. What the sequence, fulvestrant won't go away. I think we'll be using it. It's just which comes first.
Do we have any other questions for Dr. Gradisher? All right. Well, seeing none, Dr. Gradisher, thank you so much for spending your morning with us and sharing your expertise. We really do appreciate it.
Thanks so much. Have a good meeting. Stay warm. Bye.
Thank you.